everyone. Welcome. Welcome to the Massachusetts General Hospital Frontal Temporal Disorders Unit Community Forum Friday, Session 5, Home Care with Habilitation Therapy. I'm so happy to be joined today by our community expert, Dr. Paul Raia, to talk about a model of care that can help caregivers at home with their loved ones living with all kinds of dementia. These Community Forum Friday events are an opportunity for us to connect as a greater community of professionals, caregivers, persons living with a diagnosis, and individuals who need support and care at this time. I want you to know that this session, like all our other Community Forum Friday sessions, is being recorded and will be on our MGH FTD unit YouTube channel for future viewing. I'm also able to take questions from the audience. So attendees should use the Q&A function at the bottom of your Zoom screen. Type your questions in there, and I'll moderate the questions throughout the presentation today. So now it is my joy to introduce Dr. Paul Raia. Dr. Raia has worked in the fields of psychology and gerontology for 44 years. He spent 30 years at the Alzheimer's Association, Massachusetts, New Hampshire chapter as Vice President, Clinical Services. He is currently working as a consultant for several providers of dementia care and university training programs across the country. Dr. Raia developed a comprehensive approach to dementia care called Habilitation therapy. He's dedicated his career to teaching others how to connect with individuals with dementia emotionally, using the domains and techniques of habilitation therapy. He's deeply committed to the notion that many of the symptoms commonly associated with dementia can be treated with thoughtful behavioral and environmental strategies. And I just want to take the opportunity to personally thank Dr. Raia. It was about 11 years ago when I became connected with this community and I heard Dr. Raia speak. And it really changed my approach to caring for my loved ones living with dementia and has greatly influenced the way that I work with caregivers and families today. Dr. Raia, welcome.
Thank you, Katie. It's nice to be with you.
You know, I think that talking habilitation therapy feels like old hat for me, but I think that it's important that we begin our session today with a little help from you just to define it and explain at its core. How do you tell people what is habilitation therapy?
It's not rehabilitation. So we're not looking to change the person's behavior or abilities to what we would consider to be normal, but rather to enable the person to function better given where they are in the course of their disease. So it's not rehabilitation, it's habilitation. It's getting the most out of where you are at any point in the course of your disease, both cognitively and emotionally and spiritually. And it's trying to enhance the interaction between the caregiver and the person who has the dementia. If you look historically at how people thought about dementia, one area was that people thought since there was no cure for this disease, for the variety of forms of dementia, that the best we could hope for was to put all our energies into finding the magic pill that is going to cure that disease. And what we're finding is that cure is kind of a ways off. So what do we do in the interim? How do we enable family members and practitioners to work with the people who have the disease to improve the capabilities of that person at every stage in the course of their disease? so that they can appreciate the world better and interact with their caregivers in a fulfilling kind of way. If you define something from the get-go in terms of what you want to have as your end goal, that's what you're going to focus on. So my perception from the beginning was that all forms of dementia have a therapeutic component. We can make people do better at each point in the course of their disease.
That's so powerful. And I think a lot about Dr. Brad Dickerson is the director of the Frontal Temporal Disorders Unit, and he is very focused on the approach of from care to cure. And he'll say all the time, we are tirelessly committed to finding a cure for these devastating diseases. But today, we are also committed to the highest quality of care. And I believe in that too. And there's so much dignity in care with your approach as well. And I know that you're going to talk to us about the different domains connected with habilitation therapy. And I hope that as we go through those, I'll be able to help the community make some connections to how they can apply that domain to caring for their loved one at home.
Right. The first domain that we talk about is the physical domain, the environment around the person. And you can structure that environment in ways that help compensate for the cognitive losses that we're seeing. So let me give you an example. If someone is in their kitchen and there's a can of tuna in the cabinet, that tuna doesn't exist, that can of tuna, so they can't make their lunch. They can't use it. But if that can of tuna is on the counter and they see it, they're much more likely to be able to use that can of tuna to make their lunch. So one of the things we know, for example, is that with Alzheimer's disease anyway, the vision is profoundly affected very early in the course of the disease. And color is diminished. The sense of color is diminished very early in the course of the disease. So that by mid-disease with Alzheimer's, the person is only seeing the bright primary colors. And so that if we want to draw attention to things in the physical environment, we have to make sure that we're using bright primary colors to bring their attention to whatever it is we want them to focus on. As an example, research has shown that if you use a red dish for their meals, that they're going to eat more because they are able to focus more on the red dish. Or if you have a light colored food on a dark plate, that food stands out, they're better able to focus on it. And the reverse, if you have a light colored food and a light colored plate and a dark food, they're better able to see that. Research has shown that if you have a red placemat, that people will focus on eating more for a longer period of time because the red color keeps their attention. We have to be concerned about where light is in the home, for example. We don't want someone sitting across from a bright light because the glare is going to cause anxiety. The physical environment needs to be looked at from a safety perspective as well, so that we're taking out things that could cause the person to have an accident, or we're making things available to them visually and sensorially that they need to use in case of an accident. For example, we don't want to put hidden door locks on the doors when the person is alone in the home to secure them from wandering. But we may want to have a door lock when the caregiver is in the home, but otherwise occupied in another part of the home to secure the person from wandering. We got to be concerned about the physical environment. Let me give you an example. There was a man in a nursing home who would hit people. And we figured out why he was hitting people. When he's seated in a certain room and the light was coming in through the window, he would get up, walk across the room, and hit the person seated under the window, thinking he was controlling the light. So all we had to do was lower the blinds. Now, if we weren't thinking in terms of what is causing that behavior, what we would have had to jump to is psychoactive medication, which may or may not be in the person's best interest in the long term. So the physical environment is very important, and we have to figure out how the person is sensing that environment, how they're interpreting that environment, and how we can improve the environment so that they will be easier for them to interpret that environment.
So, Dr. Raia, when you think about the environment, and I think right now our target audience who we're speaking to today are folks who are caring for loved ones in the home environment.
Right.
And so do you often coach caregivers to think about decluttering their home environment, trying to simplify in some way as far as like the number of items that may be available or around?
Absolutely, yes. Make it as simple as possible so that the things that are to be used stand out. And that's the basic concept here, that you want to make sure that the person has either visual or auditory access to the important items in the environment that will enable them to function more independently.
And so as we think about decluttering the environment, taking maybe some extra items away, I also think about sometimes adding things to the environment that are cues. Like, for example, making a simple sign with a picture of a toilet and putting that picture on the bathroom door. Could you give some examples of things that caregivers might add to their home environment that could be cues for their loved ones?
Yes, I think that a caregiver, I'm relaying a story here, a caregiver would be away during the day for some period of time, leaving her husband at home. And she would put all the things necessary for lunch out on the counter. And because it was visually available and things that he could just pick up and eat, she didn't have to have a sign that said eat lunch, but because it was there, he would eat it. I'm thinking also of a caregiver saying that her husband had trouble urinating in the toilet. Mm-hmm. And so she was very clever and got red tissue paper and put it in the toilet. And that became a target for him to urinate in the toilet.
That's such a great example of using the environment and encouraging the person living with the dementia to still be able to complete a task on their own with just that cue from the environment. I really love that.
There are very clever things that families have come up with that enable the person, to be more independent. Putting the toothpaste and toothbrush visually available in the bathroom, so the person can do it on their own, or be able to at least put the toothpaste on the toothbrush on their own. And then we'll get into what we call cueing later, what caregivers will need to use to give prompts to enable the person to be more independent as well.
I just have one more question about the environment. Do you consider like auditory, so let's say the television or radio or music, do you consider that to be a part of the environment when you're thinking about habilitation therapy?
I do. And I am a real advocate for music, and finding the music that the person was exposed to and enjoyed when they were younger. And there's something magical about this. I don't know if you've seen some of the research on how that works. But if you can get an iPad or a recording device where you can play the music that the person likes and was exposed to as a younger person, it enables the person to calm down and become more aware of what's going on. I've been involved recently with drum circles with folks, using rhythm to calm persons who are anxious. And we're doing some research now that looks at how exposure to drum circles has long-lasting effects in terms of calming the person, as tranquilizing their agitation. Music is a magic elixir, and I totally recommend it. Let me give you another example. I had an aunt who had a head injury that affected her frontal lobe. And so she had many of the same behaviors that we see with frontal temporal lobe dementia. She was sexually inappropriate. Her language changed. She was an old Italian lady who was very religious, and her personality changed entirely. In the end stages of her disease, she was constantly screaming. One of the things I did was to record the rosary for her. And I would play the rosary. And when she was hearing the rosary, it was the only time she would stop screaming.
Paul, that's wonderful.
And so that was, in those days, it was on tape. So I was so afraid that the tape would break. I had multiple copies of the tape, my emergency backup tapes, just in case.
That sounds like good planning. Every caregiver should know about having backups.
Right.
I especially liked a story. I had an adult daughter caregiver caring for her mom, and she said, "Oh, my mother is a very prim woman, and the only music that she likes is classical music." So she would play it, and things would be fine. And then she had a home like a caregiver from an agency come in. And when that caregiver was there, she really enjoyed country western music and would play it. And her mother, who was nonverbal, would tap her foot and like start to move along with the music. And the adult daughter said, "I just couldn't believe it, but she really enjoyed the country western music." And it was something that she really learned by observing her mom's reactions and just paying close attention to how the environment affected her. And she was able to actually learn new things about her mom, even when she was nonverbal.
Yeah.
Sweet.
There are, in the case that I just gave you with the rosary, it was the rhythm as well as the meaning of the rosary that I think calmed my aunt.
Yeah.
And so the message to carry away from this is that rhythm in and of itself has a calming effect.
That's very powerful. And our director of neuropsychology services, Dr. Bonnie Wong, has done some work with rhythm specifically. So of course we know music is powerful, but even just that rhythm and even using your own body to make sounds and the beat can be very impactful.
Mm-hmm.
Yeah. So for the environment, so the domain of the environment, it seems that caregivers should focus on thinking about items in the environment. They should think about lighting. They should think about sound and safety. Like, are there dangerous items available, or are doors closed safely? Things like that.
And color.
And color, right?
Yeah.
And color.
Right.
Great.
And realize that with some forms of dementia, that vision is profoundly impaired.
Mm-hmm.
That the person cannot track items going across their visual field as they used to be able to do. They lose depth perception, so that the environment there can be all kinds of problems in going downstairs if you don't have depth perception. If there are people walking back and forth, they may bump into people because they are not seeing the periphery of their visual field. They're only seeing right in the middle of their visual field. So that and that's particularly the case, I think, with visual forms of frontal temporal lobe dementia. So there has to be an awareness of the sensorial loss, and then compensating for that within the environment.
That's very important.
The communication domain is the next one we talk about. And here is where I think caregivers can have the most effect, primarily in stabilizing the person in terms of their emotional status. Let me give you some examples of what I'm talking about. There was a lady some years ago who told me this experience, related this experience, where she would take her mother to a fancy restaurant every Wednesday night, and she showed up at her mother's house. Mom had Alzheimer's, and Mom was all dressed. She had her coat on, pocketbook ready to go. They got in the car, they went to the restaurant, shown to their table. Mom takes off her coat, and she didn't have her dress on. She was in her slip and her underwear. She forgot to put her dress on. So the daughter, thinking, who had been studying habilitation, she said, if I say what I'm thinking here, Mom, look, you forgot to put your dress on. That would have caused the mother embarrassment and would have obliterated any opportunity to have a wonderful meal together. So she thought for a moment. She said, it's a little chilly in here. I'm going to put my coat on. You must be cold too. Why don't you put your coat on? And Mom did that. And then they were able to go on and have a wonderful meal together. The point is that the first rule of communication in habilitation is you don't embarrass the person. You go out of your way to make sure that you're not causing an emotional, you're not bringing up the fault that the person expressed, that you're not indicating that the person's cognitive abilities are such that they can't do something. You don't embarrass the person based on where they are in the course of their disease. The story went on in this case that as the daughter and mother left the restaurant and they got into the car, and mother pulled out a handful of currency, and she had picked up all the chips on the table as she walked out. And the daughter said, "Oh no, this was a very profitable evening. I practiced habilitation and we made some money."
Oh my goodness.
The next rule of habilitation is that we never, ever, ever use the word no.
Right.
The minute you say no, you're setting up a confrontation. You're causing a negative emotion. And at the core of habilitation, I should say that it's really based on the realization that one of the last things to be damaged in the brain is the amygdala, a part of the brain that's involved in emotion. So habilitation's basic concepts are that we don't want to cause negative emotions because that is still there. It's not the sophisticated sense of emotions that occur and are interpreted in the front part of the brain, but the very basic kinds of emotions that are focused more in the lower part of the brain, in the amygdala. So in the saying no to someone sets off an immediate negative response. If the person wakes up at 4 a.m. and they say, I want to go for a walk, I think the thing you say is, it's a great idea. I don't know why I didn't think about it. Let's do it. But before we go, let's have a cup of coffee and a sandwich. And you're going to try to use time to erode their original thought. Right. And then you're going to say something like, let's have a cup of coffee and a sandwich. My favorite kind of sandwich is peanut butter and jelly. What's yours? You're asking the person to make a decision. So you're making them think about something that's different from I want to go out. Then you're going to say, come with me. Let's make the sandwich. You're causing them to first to refocus, and then redirection is making the sandwich. You're refocusing their thought patterns, and you're redirecting their actual behavior. Time will erode the initial thought of I want to go out at 3 a.m. for a walk, and hopefully you have stopped the person from wanting to go out because you used these delaying strategies.
When you say that, Paul, it reminds me a lot of the tenets of improv. I don't know if you've heard improvisational actors will say that improv is all about saying yes and. Mm-hmm. So what you're doing is saying you want to validate your loved one's idea, but then there's a but or an and. It's like something else, right?
A delaying tactic.
A delaying tactic. So it's you validate, but divert, validate, and delay. Yeah.
Yeah. Yeah. So that you're trying to move them away from that initial emotion because we know that their memories are impaired. Right. And we're trying to play on that concept, that hopefully we can change the memory or the concept.
Could you talk a little bit about when we say no, what that does with our body language or our tone and how that might affect our loved one with dementia?
Yeah, when you say no, your body language, your tone of voice changes, your body language changes. There's some really interesting research that looks at Alzheimer's patients will focus on your eye dilations. And they're very sensitive to that. And when you say no, your eyes dilate. And the person with dementia is picking up on that. And it's very, very subtle stuff that they are now attending to. So yes, when you're saying no, there are many cues that you may not be aware of that you're indicating to the person that they can't do what they want to do, and you're standing in their way from doing that. And that's what you want to avoid. That you're going to go along with what they say, but hopefully delay the process. Now, related to that is that after you've refocused and redirected, another concept is that you want to have the person um, uh, let me give you an example. The person says to you, I just saw my mother, and you know their mother is dead. Our natural inclination is to say, no, your mother died 5 years ago, to deny their reality. And that is going to cause a negative emotion. The person then says to themselves, oh my gosh, I'm getting worse. How come I didn't know that? And that's going to cause a negative emotion, which is going to linger for a period of time. So rather than try to sort of embarrass the person and by correcting them, no, your mother has died, I would recommend we say something like, tell me about your mother. How did she look? How is she feeling? What's going on with her?
Yeah.
And then refocus and redirect. Those are your two basic skill sets to learn: refocusing and redirect. You refocus their attention, you redirect their behavior.
It's so important what you're saying about thinking about addressing the feelings first, right? And really acknowledging those feelings. I like the tactics that you give about redirecting, but also tell me more.
Yeah.
Like, tell me
Yeah.
more about what you saw, like that you're interested in, you want to learn more, you want to hear what they have to say. I really like that approach a lot.
The corollary of that is that you don't want it to deny the person's reality at all. And you don't want to draw attention to the fact that their reality may not be what is actually real. But as we said earlier, you never say no. You don't want to deny that reality. But sometimes you have to use what I call therapeutic fiblets.
Mm-hmm.
And where you may have to say something that isn't true. Person says, I saw your mother, they saw their mother. And you say, well, yeah, she had to go see your brother in a neighboring town, but she'll be back. Now, a lot of caregivers have a problem with that, and they'll say, I'm never going to lie to my loved one. Sometimes you have to deal with that and actually say, use what I call therapeutic fiblets to stop the person's behavior from worsening over time, which often happens. The person may say, our daughter is in trouble, I can feel it. And you might say, I just talked to her, she's doing fine, you don't have to worry.
Right. Yeah, I'm really thinking about that as an act of love to help to keep your loved one feeling safe and calm.
Mm-hmm.
I know in one of the skilled nursing homes that we work with, there's a woman who would notice when it was 3 o'clock every day, and she would get very anxious that she wasn't at the bus stop to pick up her children. And she would start to pace by the door and get very agitated. And if the staff just told her, oh, the neighbor is picking up the girls today, they're going over for a play date, she would get much more relaxed. And,
Yeah.
and then the time would pass and it wouldn't bother her. But just recognizing and acknowledging she had those feelings, even though it wasn't reality, but it was her reality.
Right. Spouses and adult children have initially a moral kind of issue with lying. And that's why I want to emphasize that it's therapeutic, that you're doing it, as you said, as an act of love to not cause a negative emotion that then will spiral into more negative emotions and change the person's demeanor for the course of the day. By using a simple fiblet, you're improving the person's ability to appreciate the day and not get worse over time.
Right. Yep. And I would assume, Paul, that the type of fiblets that you would use would really depend on the specific individual and their cognitive ability, just everything that is unique to them, their values, the context of what they understand, and that the same fiblet wouldn't work for everybody.
That's right. That's exactly right. So that hopefully it's the person who knows the person with the dementia well enough to be able to have that information to create the more appropriate and thoughtful kind of fiblet.
So it seems like for communication, the takeaways are to practice not using the word no, and to think about validating feelings and redirecting.
Right. Yeah.
And also to consider using therapeutic fiblets when it will help to protect the feelings of your loved one that you're caring for.
Right. It's all, habilitation in general is focused on maintaining a positive emotion over the course of the day.
Yeah.
And if we can do that, I think we can keep people doing better in the course of their disease over the long haul. It's when people have periods of time when they have negative emotions that oftentimes then the need for medications which may hasten their decline. So our focus is to maintain a positive emotion over the course of the day through the physical environment, the emotional environment, through the communication techniques that we talked about, and then looking at the next domain, which is social. Excuse me, before I get to social, let me do the activities of daily living. This is an area where, again, we want to focus on maintaining a positive emotion. There are many activities of daily living that we want to make sure the person can do on their own for as long as they are able to do on their own. Let me give you an example. I was called to a man's home once, and he said his wife couldn't dress herself, and so that he had to dress her every day. And I said, well, what do you do? And he said, well, initially I would say to her, her name was Angelina. He would say, Angelina, I want you to get dressed. And she would just stand there, and she didn't know how to initiate that. And then I looked at Angelina's closet, and it was one of these walk-in closets where she had a number of choices to make. It wasn't that she couldn't dress herself. She had the mechanical ability to dress herself. What she had a problem with is selecting the thing to wear, right, from this array of things. Right. So I instructed him to use a very small closet for her, to go to the closet every morning and say, it's time to get dressed. And he would pick out 2 dresses. And he would say, we have this lovely blue dress. We have this lovely green dress. I love the green dress because it matches your eyes. Which one would you like to wear? She chose the green dress. He gave it to her. She was able to dress herself. Yeah. The mechanics of dressing. The cognitive problem was in selecting from an array of things. That is a concept that we think about in terms of all personal care, that the person may not be able to make a selection to determine that this is something they should be doing. There are several steps in something and they can't figure out the sequence of steps. Let me give you another example: brushing your teeth. A colleague of mine once did a study and found that there were 35 separate directions that you had to give in order to have someone complete brushing their teeth. And as long as you gave the verbal direction in sequence, they were able to do it themselves. But they couldn't initiate it themselves. They had to be prompted to do that. And they were cued for every step. And for a lot of personal care, that's what you need to do. You need to cue the person, but not do it for them. And you don't want to initiate doing things for the person before they're truly unable to do it for themselves. And I think a lot of caregivers do that they may take over a personal care event before the person has actually lost the ability to do it for themselves, because they should prompt, they don't know how to prompt the person to do it. And that's a very important concept, I think, for folks. So dressing and toileting is another issue that we talk about a lot. And sometimes it's finding the bathroom. In some cases, putting a sign on the door that a picture of a toilet that may be helpful for some people. Oftentimes what I suggest is that you put a colored toilet seat on the toilet, or you paint the wall behind the toilet a bright color so that the toilet itself stands out in the room and it's the focal point. You leave a light on in the bathroom all the time. We don't want to initiate using adult diapers before they actually need it. Mm-hmm. And it may be that the person could use an adult diaper at night, but not during the day. And you have to make that decision, what's feasible. But toileting is an issue that a lot of caregivers, particularly male caregivers, have a problem with, initiating showering and toileting. Showering is another issue where people have lots of problems. And what we have found is that it's water in the face that a lot of folks have problems with. So that I often will suggest you use a handheld shower nozzle, and you give the person a sponge to hold, and they may be able to shower themselves with verbal instruction or cueing. But at some point, maybe you hold the shower nozzle and shower them from the feet up and stop at the neck. Do not get the face wet. The person may be able to lather themselves in the shower. And so you enable them to do that until they lose that capability. You may have to do it. But the key here is do not get the head wet. If you want to wash the hair, wash it separately at the sink, or use one of these powder shampoos that are less threatening to the person. But making sure that, let me give you another example of one of the things that a family member did. Her husband loved the music of the Beach Boys. And in order to get him in the shower, she would play the music of the Beach Boys in the bathroom. And she would dance him into the bathroom and help him undress and get him into the shower. And then the music's still playing, and they would both sing the Beach Boys music while they were showering. And it took 5 minutes. They were in and out, and he didn't have a problem. Again, music being so important in the care of folks, and it's something we use in habilitation all the time. So the personal care is very troublesome to a lot of caregivers, particularly male caregivers who never had to do that for their spouses. And I ran a men's group, and that was the #1 issue that they always talked about, having to do personal care with their wife. But it's looking at what the person is still able to do, allowing them to do that part of the task themselves, using cueing, but then taking over that parts of the task they can't do, and making it more fun and less embarrassing.
Yeah, for embarrassing, I had one wife who she noticed that her husband didn't like to remove his underwear. You know, he didn't want to be completely naked in the bathroom with her. So she started off by just letting him get in the shower with his underwear on. And then she would say to him, "Oh my goodness, this underwear is all wet. We should take it off." And then he would be fine with taking it off once he was wet, because then it was uncomfortable. So she just realized she didn't need to fight him to be naked when he went in the shower. It was once he was in there, she could get it off. So I think that's a really great example of being creative
Yeah.
with your.
Sometimes I hear of taking the person into the shower with their bathrobe and just showering them with their bathrobe on.
Right. And they just wash it. It's
Yeah.
fine. Yeah. Yep. That's great. That's great. Thank you for that. I know so many people, personal care is such a challenge.
Yeah. The next domain is the behavioral domain. And here, we see a number of behaviors that are difficult to kind of understand. And what I want family members to think about is that all behavior has a source that is related to emotions. And if we think back as to the trigger for that emotion, we will better understand how and why the person is behaving the way they are behaving. Let me give you an example. Man in a nursing home who would hit other people. And as I said earlier, I actually gave you this example earlier, didn't I? That he would hit the person under the light. But we call this sleuthing. So to understand the initial source of the emotional change that caused the behavior. Another example, this was a man in a nursing home who had been in the military, was an officer in the military, and he felt as if he needed to protect the women in the nursing home from unwanted advances from the other male residents.
Mm-hmm.
So he was sort of, in his mind, thinking he was protecting the women from the other men. So if a man came up to the particular woman and started a conversation, he would push them away. Mm-hmm. And so we figured out one of the ways to deal with this was to say, and he happened to have been a major in the Army, Major so-and-so, stand down. That's all the staff had to say, and he would.
And he would respond to that.
He would respond to that. Or we would say that Colonel so-and-so has said that he wants you to report to his office. Let me take you over there. And then you would refocus and redirect as you're walking away. So understanding the person's personal history mm-hmm. is important. And being able to use sometimes therapeutic fiblets to move the person away from their initial intention, to understand the source of the behavior, both the emotional source and the cognitive source of what initiated that behavior, and then to try to change what that is, and the chains of events that relate to that behavior. Families oftentimes will react to the event, but not understand what the person may have been, how the person may have interpreted the event in the first place.
Right.
Let me give you another example. This man had frontal temporal lobe dementia, and when people came into his home, he had still fairly young children at home. If someone was paying attention to his daughter, he would interpret that as they were being sexually inappropriate with his daughter, and that he would intervene and often intimidate the person physically from being near his daughter. And if we understood the source of that and we were able to anticipate it, we could avoid that behavior altogether.
One of the things that can combine when we think about the domains of communication and behavioral symptoms, what happens when our loved ones have trouble communicating and they become frustrated? So, for example, not all of our loved ones would be able to express verbally maybe what they're thinking or something that they're worried about. And so you might see behaviors linked to communication frustrations. Do you have specific coaching for families that are dealing with loved ones that have difficulty verbally communicating?
Yeah, I think the first thing is that you empathize with the person verbally and say, I know it's hard for you to express this. Let me try to understand. And I often encourage the person, the caregiver, to use touching at this point. And you're saying, I know it's hard, to touch their hand, to touch their arm, and say, I know how hard it is for you to do this. Let's try to figure out what it is you're trying to say. And then offer options that the person can say yes or no to. But I think you have to empathize right at the get-go and say, I know it's difficult for you, and I understand.
And so using that tenet of validating the feelings.
Right.
And when you speak about touch, Dr. Raia, would you say that the same level of touch or sensory input is appropriate for all patients or individuals living with dementia, or is that individualized too?
That's individualized. You know, I really think that my experience has been with FTD that some folks don't like to be touched. So you've got to know the person, and it also depends on your relationship with that person, where it's okay for the spouse to touch the person, but it may not be okay for an adult child to touch the person. And so it's a issue of finding out what works for that particular individual with other individuals. For the most part, if you, I often say that you have to make sure that you're facing the person directly, and you make eye contact. Understand that the person oftentimes in later stages of the disease may be responding more to your body language than to your verbal language.
And your
So you've got to be
tone,
very
maybe.
conscious of your verbal language and what you're communicating to the person, and that you're making eye contact and you have a big smile before you initiate touching. What some interesting research has been that folks with Alzheimer's, I'm not sure with other dementias, but with Alzheimer's, their eyes dilate in synchrony with the caregiver's eye dilation. So that once the eye dilations have actually synced, that's the time when you can initiate touching, because there is then an emotional, a neurologically emotional connection has been made.
I really love the way that you say that, because I think it really draws this connection to a symbiotic relationship between the care receiver and the caregiver. And I think that as someone who has loved someone with dementia and still loves someone with dementia, my dad, I know that as much as I have given to him as a caregiver, he's also given a lot to me through our ability to continue to make emotional connections, regardless of his cognitive abilities. Yeah.
And your facial gestures are so important. And a lot of times caregivers may be saying one thing, but their facial gestures aren't in synchrony with what they're saying.
Right. Yeah. We all have to watch that.
Right.
Dr. Raia, as we get close, we're at the end of our hour, and I want to be respectful of everyone's time. I just wanted to ask, is there anything in summary that you want to share with our audience of caregivers today?
Well, first of all, I think this particular time where I'm assuming that a lot of caregivers who may have been using adult day health programs or aren't able to go out of the house as often as they'd like, things get more intense now. We're limited to our homes. And so these skills, practicing these skills are even more important now, because like everyone, the person with dementia is going to get a little bit agitated just by the fact that they have to be in the house all the time. And you're having more one-on-one contact. And I feel that folks who were using adult day health or had other caregivers coming in, and now that isn't happening, this is a very difficult time for them. So all the more important to think in terms of balancing the emotions, looking at the emotions of the person with the disease, and being aware that that's how you're going to communicate with the person. And it's going to help the caregiver if they focus on emotions, and it's going to help the person with the disease. There's that reciprocity that exists. And these days, it's all the more important to really think about emotionally connecting with the person in a positive way. The other thing I probably want to suggest is that this takes practice, and you're not going to be good at it right off the bat, but you work on some of these skills and give yourself time to get better at the ones that are important to you. Habilitation focuses on enabling the person to maximize their potential for where they are at any point in the course of the disease, whether that be early stage, middle stage, or late stage. So we shouldn't get frustrated when the disease itself moves the person to another stage. But that then means we want to maximize that person's capabilities within that stage of the disease. That's therapeutic, and that's what we work towards. Once we think in terms of therapeutic interventions, particularly if we're talking about spouses and adult children, then we can have a better relationship and a better emotional relationship with that person. That's what's important. That we're not reacting to the person negatively because we can't control their behavior. We're working, we've stabilized the person for where they are in that stage of the disease, and they're in a better emotional place where we can have more positive emotions back and forth.
That's so important. And I think at this time, more than ever, we're thinking about what are the things that are most important to us as individuals, as families, as communities, and those that we love. And focusing on that is, of course, going to be central.
Right.
And as we wrap up today, I also want to remind every caregiver out there that if you're feeling like you're having a tough time and you want to talk about these things, there is support available. The Alzheimer's Association is offering still their 24/7 hotline. The Association for Frontal Temporal Degeneration is offering a hotline where you can call and get help. And both of those numbers are posted on the association and AFTD's websites. And that the Mass General Hospital Frontal Temporal Disorders Unit is offering online support groups that can be found on our registration site for support groups and Community Forum Fridays. But Dr. Raia, it's been so valuable to have your expertise today. And I just want to thank you for everything that you have done for our community, the thousands of families that you've impacted with your work. And it really is just so meaningful to me, and I know many others.
Thank you, Katie. And good luck to all the folks out there who are giving care to those they love. Love is a verb. I want people to remember that. Love is a verb.
Love is a verb. I think there's no better ending. Thank you so much, Dr. Raia. Bye.
Bye-bye.